Howdy, everyone. I'm Megan Badejo, and I'm an MS3 at Texas A&M, and I'm also the Community Service Co-Chair for the National SNMA. And I'm going to be your host today for our Surgery Specialty Series. So this series is part of our Sowing Seeds program created by our amazing National President, President Office Obo, in collaboration with the Alumni and Multicultural Affairs National Committee. Throughout this year-long program, we will be providing resources to success for our pre-meds and medical students and anyone generally interested in medicine, and how to stay just abreast and aware of anything from financial literacy all the way up through taking your exams and your national boards. So make sure you are in the know with SNMA by signing up to be a national member at snma.org. And when you do that, you'll be in the know. Okay, everyone. So I'm just going to jump right on into this series and introduce you guys to our amazing panelists. So first up, we're going to have general surgery resident, Dr. Rita Erhunmwunsee.
Hello, everybody. My name is Rita Erhunmwunsee. I'm a general surgery resident, first year incoming at Temple University Hospital in Philadelphia. Went to Drexel University College of Medicine in Philadelphia for med school. I actually have a long history with the SNMA. I love this group. Last year, I was the national vice president. For that, I planned the conference that was in Philadelphia as the chair, and then some other positions as well. And I'm really excited to be on this panel and let you guys know what's going on with surgery and how you can get in.
Absolutely. We're happy to have you. Okay, so next up, we're going to have Dr. Olivia Means, who's an integrated plastic surgery PGY2.
Hi, I'm Dr. Olivia Means. I'm a plastic surgery resident, PGY2, at Spectrum Health Michigan State in Grand Rapids. So nice to be here.
Happy to have you. Up next, we're going to have thoracic surgeon, Dr. Loretta Erhunmwunsee.
Hello, hi, I'm Loretta Erhunmwunsee. I am a thoracic surgeon, as mentioned. I'm very grateful to be here and excited to talk to you guys about cardiothoracic surgery. I went to undergrad at Emory and med school at Harvard and had a great time with SNMA. I am very honored to be back here talking with you guys and look forward to the discussion.
Absolutely. Up next, we have trauma surgeon, Dr. Dirk Johnson.
Hello, my name is Dirk Johnson. I practice trauma, acute care surgery, and surgical critical care in New Haven, Connecticut. I'm a faculty member at Yale. How did I get here? I went to Morehouse for undergrad and then went to med school at Yale and trained a little bit meandering through Rush, Vanderbilt, and finished at UTMB in Texas. I did my trauma fellowship and acute care year at Yale, and I've been on the faculty there ever since. And recently, in addition to doing that, I've gotten into a bit more administrative work in the last few months. And I'm happy to talk to you all.
We're excited to have you. And then last, but definitely not least, we're going to have our breast surgical oncologist, Dr. Ronda Henry-Tillman.
Hi, how are you guys? My name is Ronda Henry-Tillman. I'm the chief of division of breast surgical oncology and the vice chair of the Department of Surgery. And I'm excited to be here. I remember being in the Student National Medical Association and the great opportunities that it led for me. So I look forward to talking with all of you.
Absolutely. So you guys, super excited for this amazing panel. I mean, just the wealth of knowledge and the range. You guys, let's just get into it because I'm excited. So they've kind of already told us a little bit about, where they are now. But for all of our panelists, I'd love to hear a little bit more about you, your personal journey and getting here. But I'd also like to know, why you chose your specialty. Like, y'all are all so different. And did you guys have mentors in the field? You mentioned NCMA for some of you, but some of you didn't. And at the end of the day, like, what is something that is your, I guess, favorite part of why you do what you do? And we can start with Dr. Rita Erhunmwunsee.
Thank you. Yeah, I think my first interest in surgery came during my third year. Prior to that, I thought I was going to be a pediatrician, but I had never been in the OR at all, had no procedural knowledge or background or experience. And then when I got in the OR on my third year rotation, I think something changed. I was on a transplant rotation, and that first week of my rotation, I was actually on call, and we got a call about a deceased donor procurement. And we went around 8 p.m. and we're in there, and it's me, a mid-level resident, and the attending's already got the organs on the back table. I'm in front of on the main table with the resident, and we are in the belly, and it was amazing. It was so cool to see the full spectrum of the anatomy, and I'd never felt that type of rush on any of the other services, any of the other rotations that I was on, not even pediatrics, and I love pediatrics. And I think it was around that time that something changed for me. So that was, and after that, I think it was fate. I know it sounds very cliche, but I think that's what it was.
That's amazing. And you said, did you come in wanting to do pediatrics?
I'm a changer. I changed directions. Yeah.
I love it. That's amazing. Okay. So thank you so much. I'm actually going to ask Dr. Dirk Johnson to hear what he has to say as well. And you are muted.
Likewise, I showed up to medical school thinking I was going to do something very different. I started out interested in obstetrics and I guess moved down the alphabet and was seriously considering orthopedics, and then finally ended up in general surgery. And as I went through my general surgery training, I realized I had an academic interest in sort of glucose control, and sort of debated at the end of training, residency training, about doing MIS for minimally invasive surgery versus surgical critical care, and ended up in surgical critical care, which I think fit my personality better. I had a lot of involvement with SNMA, and having conversations with many of my friends through SNMA nation, across the nation, helped solidify that. And also, the third year rotation was really, I think, one of those aha moments when I went and knew that I was going into some surgical specialty. When I was on my surgical rotation, I realized I'd spent 12 hours in the operating room, and it felt like it was 2. I knew that was one of those bugs that you can't really satiate any other way. And so I went ahead and did surgical training, and have been happy ever since.
That's awesome. And so I know you kind of talked about how you shifted from OB-GYN and then you were kind of thinking ortho. Did you have a mentor as you were going through this process that helped you land at trauma?
Well, the trauma part was, I think, didn't come until very late in the process. And I didn't go straight through to fellowship. I took a year off for some family reasons, but it was clear that those two things, and I have trauma fits my personality, is that I never get too high or too low, and tend to be fairly calm under pressure.
That's amazing. Okay, well, we're definitely going to have more questions, as I can see, on that later. But I'm actually going to go ahead and ask Dr. Olivia Means to tell us a little bit about her experience and her journey to where she is now.
Hi, thanks for having me. I'm a plastic surgery resident in Grand Rapids, Michigan. I knew I wanted to do surgery when I entered medical school, but I wasn't sure on what specific specialty. What landed me on plastics was it kind of combined everything I was interested in. So I get to work with adults and kids. I get to work all body. You get nice variety from trauma and reconstructive cases to cosmetic. and it was definitely a reach. And so I think just outside of medicine, one of my favorite things is talking to younger students about kind of what their dreams are and really pushing for something big. And I knew I couldn't do that honestly if I did myself for something that was big for me. And so plastics, I was in one specialty.
That's amazing. And we have a lot of pre-meds on and medical students who are interested in plastics. So we're really excited to have you. I did want to ask you, did you know going in that it was plastics?
So plastic surgery was the first thing I shadowed, and that I didn't. When I started shadowing on plastic surgery, it was really just to get the experience. But once I started shadowing, I realized that I really do enjoy this, and so I think the early exposure helped me. Um, and so I think if you're interested in plastic surgery or interested in surgery in general, I think getting that early exposure somehow, even if it's just finding a mentor or getting in the operating room, that way you can kind of build your resume so that it has all the pieces needed to really have a strong application. But prior to that, no one in my family is a surgeon or was specifically in that regard. And so before that, I really didn't have any idea. And so I'm really happy that many people on listening. And so if you're interested in plastic surgery, general surgery, really anything, getting that early exposure, I think really is helpful.
Absolutely. Thank you so much. So now we're going to move on and talk to Dr. Loretta Erhunmwunsee and hear what she has to say.
Hi again, thanks everyone. So I went into medical school certainly thinking that I was going to do emergency medicine. I liked the thrill and was excited about just, being that person who can fix whatever came in front of her. And then I got on my surgical rotation, and it was different, just as was stated earlier. And I think it is very important to sort of get a sense of how you're feeling during your rotation and how you're experiencing the OR. And so for me, it was amazing. And one of the things I know about myself is that I love working with people. I rather do something collectively and collaborate than do it on my own. And so for me, it was really a no-brainer, especially once I got in the rotation. I love working with the scrub tech and being the assistant at that time and anesthesia. And so for me, it was always, it was fun. We all could learn from one another. So for me, it was very, it was clear. And also I wanted to be the type of doctor that my residents were. And so, my surgical residents in particular were just like strong and fierce and knowledgeable and confident. And I was like, well, yeah, that's exactly the type of doctor I want to be. So I realized soon, or as soon as I was on the surgical rotation, that I want to be, going to general surgery. But then once I was on general surgery as a resident, we rotated on cardiothoracic. And once I saw the chest, I was done. I knew that was a place for me. I love the anatomy within the chest. The heart, the lungs, the esophagus, the PA, the pulmonary vein. I could go on and on. I just felt home in the chest. And so for me, after that, it was done. And so certainly, the training was long, but it was all worth it. And I will say to any person who has an interest in cardiothoracic surgery or surgery in general, that in my mind, the time is worth it. You don't want someone operating on you who, did their residency online, right? You need someone who spent the time and has the experience. And so, hopefully that won't be too much of a barrier for folks. But I will say now I am a thoracic oncologist. So my main job is to take cancers out of people's chests. So whether that be lung cancer, esophageal cancer, and, and I love every minute of it. So again, I would say that the best days are always yet to come. Like hopefully you're enjoying, either college or medical school, but understand that residency is even better. Fellowship is better after that. And then certainly being staff or an attending, to me is the best, because I think as you increase in responsibility, it honestly allows you to be more satisfied and to walk in more purpose. So yeah, those are my early 2 cents.
No, that's amazing. So thank you so much for sharing that with us. And I also want to ask you, because you did subspecialize, and so as you were following that trail, I know you expressed like you were falling in love with it. Did you have guidance? I asked Dr. Johnson something similar, but did you have guidance as you went through this?
Yes, I certainly did. So in my general surgery residency, it was actually 7 years, and 2 of the years were for research. And so during those years of research, I really sort of connected with some of my attendings, and they helped to guide me, like, what should you do to stand out, and how do you, what do you want to, how do you want to sort of create that career? So I would say, and that is important. And I think sometimes we sort of want to go it alone, but if you see someone, even if they're not in the exact specialty, but certainly if they are, you can go up to them and talk to them, and potentially, talk to them about research opportunities, or ask for guidance about how to get to the next step. I definitely think that's important.
Absolutely. Thank you so much. And so next, we're actually going to talk to Dr. Ronda S. Henry-Tillman and hear her take on medicine, her journey, any mentorship, her favorite part about it. Please let us know, Dr. Tillman.
Oh, wow. My take on mentorship is just key. And I've always had very strong mentors to guide me, or I wouldn't be where I am. But, I attended the University of California UCSD School of Medicine. And I'll never forget, I got my first exposure to surgery in a research lab. And I had to prepare the rabbits for surgery. I was so afraid of these rabbits. They were so big. I'll never forget. But we had to get them under anesthesia and prepare to open their heart to do heart surgery on it. And finally, I got to the point where I could grab the rabbit. And when I was able to do the surgery, I just never was going back. And as a first year at UCSD, we did anatomy was in our first year. A lot of students at the time did anatomy in their second year. And so that just took me that step further. But when I went to get a mentor for surgery in my first year, I was told that females couldn't do surgery. And that at the University of California in San Diego, the chairman said that he would never finish a female surgeon. He said he had 2 in his program, and after the 3rd year, they were going to the lab, and he did just that. So knowing that information, I continued to seek out mentors in surgery and leaders, and but stayed with wanting to be a surgeon. And he finally agreed to give me a letter. And he said that, but he didn't think that I should come to UCSD because he hadn't finished a female surgeon. And so knowing that, I interviewed and made 12 programs. And I was from Arkansas and had quit school at the age of, left high school at the age of 16 and moved to California and had to get back into school. And so, I said, well, maybe I'll try the South. I don't know, the South has done some incredible things. Having one of the first Black medical students accepted into school, Edith Irby Jones, and they had done some amazing things. And I said, I'm just going to look in the area. I looked at Emory, and I looked at Arkansas. I went back to Arkansas, and I just fell in love with the programs and was able to match at the University of Arkansas. And amazingly, I have been there since residency, fellowship. I've gone from instructor to full professor, division chief, and now vice chair of the department, with lots of different things that has made a difference. So
that is amazing. Thank you so much. And you really did bring up a really interesting point when you mentioned that the director was not supported with basically a female surgeon going through the program. And so I know for a lot, myself and many other female surgeons or surgeons in the making pursuing it, like what advice would you have on that specifically in moving forward? And how did you kind of carry that? And what can we expect?
When people tell you you can't, or there's always, I found out over the years that you can, and you just keep looking for that door to go through. In the time when I finished medical school, they didn't even have a lot of Blacks that were going, African Americans being into surgical programs. And I met a lady in Atlanta when I interviewed at Emory. She was the first African American female that had gone through Emory's surgery program. And so just continue to push forward and go for your dreams, and we still struggle as females in surgery. And 2 years ago, our department had one of the first programs that had all of their categorical residents were females. And so still in leadership, African-American females, we're working. We have some gynecologist chairs. We're working for chairs in the Department of Surgery and other leadership positions, but we still lag a lot in the leadership arena. And just to add, as I went, I started asking, why can't I be the chair? And well, they said they didn't think about me. You didn't? Wow. So you continue. Sometimes you have to ask for what you want.
That's amazing. Okay, so we are actually going to move on to our open question segment of this. All of our audience members are sending in questions right now. And so the first question on here is, what is the biggest misconceptions about your surgical specialty? What surprised you the most during your surgery rotations? And anyone want to take this? Oh,
sure. I can answer with that.
We're both
and I'll speak from the I'll speak from kind of the newbie sort of naive side of things. So I think when I was a med student and I was sort of figuring out where I wanted to go and what I wanted to do, one of the things that surprised me about surgery was that it actually is a very well-rounded and very well-rounded specialty. And what I mean by that is that it's not just you doing procedures. You do procedures, sure, but you also manage those patients, and certain subspecialties, actually many of the subspecialties, you go on to follow them, in the clinic afterwards. You go on to follow them and manage them outside of the post-op period, or the immediate post-op period. And I think it serves, and it lends itself to that well-rounded experience where you're not just in the OR, you're in the OR, but you're also in the clinic and you're on the floors. And I think I really like that about surgery, because it's like a start to finish type of thing. And that's what surprised me. The other part was that when you hear about surgery, you hear about the stereotypical sort of lifestyle and the type of people who tend to go on to be surgeons. And honestly, I don't really buy that. I find that the culture of surgery is changing, from my point of view, is changing in such a way that they're really sort of being very flexible with at least with the residents, about making sure you maintain a life outside of the OR, outside of the hospital, while being happy in your program. And I can appreciate that.
That's so awesome. I want to see if Dr. Olivia Means could add on to what you just said.
Who did you say?
Dr. Means.
Hi. So plastic surgery is easy. The biggest misconception is all we do is cosmetics. That's not true. And so I think one of the things with early exposure to any specialty is you really get to see what do. Some of my favorite things for plastic surgery is hand surgery. I love working with the trauma service, and so we do a lot of reconstructive procedures, working with orthopedic surgery, and so I think that side of cosmetic surgery that plastic surgeons do that I just love. And I think, just echoing what was said before about what surprised you most during your surgery rotations, it's really that you do fit in with surgery. So I guess some people don't, but don't walk in there with this kind of looks like this, talks like this, is from here, has always certain things. If you truly love surgery, you fit here. And so I was surprised by that, because I've heard all of those things about why I look or I'm different or all those things, and I love surgery. I have the stamina for it. I have the initiative for it. I love the cases, and so if whatever field of medicine that you find that you love, you do fit there, and I have to encourage you guys to know that.
I'm just getting excited. I'm like, when can I start surgery? Okay, thank you so much, Dr. Means. We're actually going to move on to our next question. It's from Taylor Farrow. Hey, Taylor. What if surgery rotation is the last rotation and it got pushed back to fourth year due to COVID? How can you make up the late exposure to surgery prior to residency applications?
As long as you're you have a grade in surgery, the lateness in the rotation, I don't think, is a fatal situation. The problem or the risk becomes that you actually get to your fourth year surgery rotation and realize you don't like it. And that's when you start scrambling, and this happens. And I'm sure everyone knows somebody who showed up to third year thinking they were going to be a pathologist and realized that they really wanted to be a dermatologist. And being late and deciding to do something different is what is more problematic than if your fourth year rotation confirms your desire to go into surgery. It shouldn't be that much of an impediment.
Also, I think you might have a little leeway because I believe the ERAS application submission date got moved back a month, or moved to October 15th instead of the traditional September 15th. Hopefully that worked in your favor. I think it should. But that's a little positive glimmer of light, I think, to work with that moved surgery rotation.
Thank you. Okay, so our next question is also, how would you recommend getting into the OR before medical school if you don't know any surgeons personally? That's a good question. Let's see.
I emailed. Sorry. Can people hear me?
Yes, we can hear you. Go ahead.
Oh, perfect. Emailed different things so I went to undergrad at the University of South Florida, and I emailed different surgeons within that program. And so I think, and that was for me because I didn't know anyone, and I don't really know what the right or wrong way is, but kind of starting from there. You don't always have to start with the attendings. You can start with emailing the different residents there. It is difficult because there's a lot of work going into getting access to those hospitals to really let you get into the hospital, and especially with COVID, there are things with like PPE and having enough supplies that I'm sure it's going to be more difficult. But I think, again, surgery is so much outside of the OR that even making that first step to introduce yourself and getting a mentor in a specialty is a huge step. And then getting more exposure to different aspects of care, I think will come later.
Okay, here's a question directly for you, Dr. Means. As a resident, what tips do you have for medical students with regard to applications and the interview process? Any common questions, credentials, accolades they were looking for, if possible, for residency in surgery/plastics? This person is looking for some answers.
Okay, well, things that are just accepted and really good are research. And so if you've been a part of any project, specifically projects that have been published, but if you've done any type of research program or presented anywhere, that always looks good. Credentials, if your school has AOA, which is like the honor society for medical schools, that's always great to be a part of. Not necessarily a requirement, but something that shows that you're at a certain level academically. Recommendations are really important. And so getting strong letters from people who know you well is very, very important. And sometimes really knowing, does this person be able to write a letter? And so again, that early exposure, showing that you have initiative, speaking with this person, I think really give them enough information about you to make a good letter. And then for actually doing your interviews, I think being yourself. Of course, showing up on time, all of that matters, but you're interviewing the program as much as they're interviewing you. And so it's important for you to be yourself, because residency only works if it's a good match. And so you need to find a place that is excited to have you and excited to teach you, and so they need to know who you are. And so I think bringing yourself to that interview is really important. Your best self.
Yes.
If I could offer a perspective for somebody who sits on the other side of this when interviewing candidates for residency, the things that matter sort of most and make for the best interviews are people who have identified a intermediate long-term goal and can tell a narrative of their life story to that point, as to why they've gotten to where they are and where they're going, and how where you are is going to help how whatever residency you're applying for, whatever program you're interviewing at, is going to help you get to those goals that you have identified for them. And that sort of personal narrative is the type of winning interview that is as important as your credentials and presentations along the way.
Can I add really quickly before the next question? I would say it's also important to try to go to meetings if at all possible. And the reason is because, you know, you might meet some of the people who could tell you more about programs and who will be on the interview panel, and you get advocates at different places. And so one thing that I wish I had done more of is go to like the society meetings that are typically annual. Now, if you could present at those meetings, that would be amazing. But also just going and meeting people, meeting residents at particular programs, or meeting attendings at programs, then they can tell you about their particular organizations, and again can be an advocate for you. So I would say that is not, I totally agree that papers and experience and being your own whole self is important, but also connection and trying to really do that. For instance, I'm a member of the Society of Thoracic Surgeons, and so anyone who has an interest in cardiothoracic surgery certainly is invited to that type of meeting where we could meet and talk, and there are so many other people that you can connect with as well.
You guys, we are getting the inside scoop here. This is amazing. Okay, so next question. Any advice for those juggling the idea of I6 CT surgery versus the traditional route, Gen Surg, then CT surgery?
I would love to speak to that. So I would say that so there are benefits to both, obviously, right? Like, so most would say that the biggest benefit to I6 is that you can truncate, or you can get through the whole residency experience in a shorter period of time. And I would tell you, I did the traditional route though, and really did enjoy it. And I think so, if you are going to do more of a thoracic lean, meaning as opposed to cardiac, then the saying previously was that, doing the traditional route might be more favorable for you because you would get more time on general surgery, doing more cancer cases, which you might see a lot of in if you were to go thoracic, and you also would do a lot of foregut cases, and so I would say then still, I think there are a lot of people who think about that if thoracic specifically versus cardiac is what they're interested in, then that they might lean more towards the traditional realm. But there are some I6 programs that allow and are focused on thoracic focused people as well. And so I would say then, if you don't mind, for instance, giving up your chief year, or if you don't mind, actually not having all of those surgical years, then the I6 program is a great one. I certainly feel that, again, connecting with people at different institutions, getting a sense of what their experience is going to be key. I, again, did the traditional route and am very glad that I did. But I know people who did I6 and are also very happy.
Thank you. So our next question is, do you feel that you're able to form meaningful connections and relationships with your patients as surgeons? And Dr. Tillman, we haven't heard from you. I don't know if you'd like to answer this.
Yes, I follow patients for years. 20 years I have patients that I follow. As a cancer surgeon, a surgical oncologist, breast surgical oncologist, the follow-up mainly is in patients is every 3 months for 2 years, every 6 months, then you go to a year. Because we are in a multidisciplinary cancer program and have a survivorship program, our patients remain with us and we have these meaningful relationships. And often the patients are like, you're my primary care doctor. I'm like, no, I'm your cancer doctor. And you work with them through so many things, because the amazing thing with cancer treatment is that it changes the body of the patient and they have different side effects from the different medications, and the impact on the heart, the impact on neuropathy, so the impact on sexual dysfunction, especially as a breast surgical oncologist. So you spend a lot of time with those through that journey throughout their cancer care.
Thank you for sharing that. Wow.
So I think that, if I could chime in here, the relationship you have with your patients has a lot more to do with what kind of job you have than whether or not you're a surgeon. And there are primary care docs that don't have good relationship with their patients, and there are surgeons that have great relationship with their patients. And it really just depends on what kind of practice you end up in and whether or not you have that longitudinal exposure versus a short-term experience with them.
And Dr. Johnson, I know you said you're more administrative now. Do you feel that you are still interacting with your patients, or?
So let me put some context on more administrative. I'm about 15% administrative as opposed to 100% clinical. And that's there still is, as an academic, research projects and those other things that still are going on in the background as well. But I only brought that up to sort of point out that there are other things that sort of branch off from surgery, and sort of hospital and physician leadership is one of those other things that can come on the other side of a surgical training, as well as internal medicine and other specialties.
Thank you for sharing that. And so I think we're going to go to the next question. Okay. So as a current college student, I constantly think about the cost. Girl, I understand. Did you also have those thoughts? How were you able to overcome them? Thank you.
Blind faith.
Yes. When I finished school, this is Ronda Henry-Tillman, I was $289,000 in debt. And that's from college to medical school. And, when I got into academics, one of the first things I looked at options to help cover that debt. And there are many options. And I applied for the National Institute of Health Loan Repayment Program. And within 4 years, I had all of my debt paid off. I took the route of doing clinical research, health services research, and was successful in getting a couple UO1s and R grants that allowed me to have that opportunity. There are other programs. I'm practicing in rural area that writes off loans in different places. So it is going to be a cost. And for me, when I started school, I didn't have a financial plan. I went in thinking I would apply for student loans, and those were my options, and student aid. But the bills continued, and not just paying for school, but living. And in medical school for me, living in La Jolla in San Diego was one of the most expensive areas you can live in the San Diego County area. So I didn't have a great financial plan. I think that we should start thinking about financial planning as you go. You're always going to have to, some people don't have to have debt, but I did in my situation, and I thought of it often. And I didn't plan early enough, but I was able to plan later.
Thank you for that. So then, to our female panel members, do you feel that you're able to engage with your field and also balance your home life, raising your kids, time with a significant other, ECT? So Dr. Erhunmwunsee, do you want to take that?
So I just got here. I'm only on day 3 of my rotation. I will say after day 3, I do feel I can do some balancing. I do feel okay. Now I don't have a significant other. I don't have any children either. But I am from New Jersey, right over the bridge, and I actually go home a lot to take care of my mother. And so I think I'm able to balance that sort of work-life relationship, I think, quite well, given 3 days. We'll see how I feel after a week or two. But yeah, I'll probably punt it to someone else who's got more experience in this game.
Okay.
I can address that a little bit.
Well,
Dr.
if I can. Oh, go ahead.
One of the things think about as females is our biological clocks. And as you finish your residency, when you choose to have your children, was a difficult time for me. And so, but once I did have children, it's a work for everyone. Everyone works, everyone has 24 hours, and you have to learn time management because your family is an important component of your life, and you have to integrate the whole picture because if you don't, it doesn't work very well. So.
Right. And Dr. Erhunmwunsee, I know you wanted to add.
Yes, absolutely. I would basically echo what Dr. Henry-Tillman just mentioned. I don't know anyone who has better time management than the surgeon. I'm just going to be very, very clear about that. And so you learn that very early on. I will say that with good time management, good organization, good sort of strategy, you can have balance. I think it's very important to understand that even as a surgeon, you are the one who prioritizes what's important, right? And so you have to, and so I, as a surgical resident and fellow or CT surgery resident, my time was not my own a lot. But when it was my own, oh, listen, it was planned out to the T. And the things that were most important got done. And so I think you become expert at balancing all of the things and actually doing usually a really good job. Now, as an attending, now that I'm done with training, I feel like I have so much time. And it's funny because like I'm very busy now. Like I do just as many of the other panelists, I certainly have a clinical practice, but I also do research and have some administrative duties as well. And so, there is a lot that you have to balance personally, professionally. And again, I think as surgeons, we usually do it very well. So for the person with the question, it is certainly possible to do it. And I would say, is as you're going through your rotations and training, think about the type of special, I was looking at what did my attendings, what were they doing during the day? What were they doing at night? What were they doing on the weekend? You know what I mean? And you can figure out what kind of involvement you want to have, meaning that not every surgical specialty has you in the OR all day, all night, every day of the week. In fact, most surgical specialties you can plan your day, and so I would say take a very good look at that and know that yes, you will have to prioritize, but that you will become an expert organizer who can really get good balance.
Thank you for that insight. I know people tend to ask that question because there's fear of retaliation when you want to take time for yourself as a woman. And I don't know if any of you experienced that, like you want to have a child and you're looking into your residency or your fellowship or something like that. Did that ever impact you at all, or you were able to keep it moving?
So I would, please, for everyone, make sure you've talked to folks who are in programs while you're interviewing. Be very open and honest about the questions like that. I would say that most programs now are not going to retaliate for a person who wants to take time off for childcare in any way. That's so frowned upon, and it's illegal. So people aren't really doing that these days, but certainly there are some programs that are better at that. And so, when you're interviewing, when you're getting to know residents and getting to know programs, ask those questions oh, what's the policy? What's the process? Have you had residents who've done that before? Did they finish with this program? And you can ask questions like that to get a sense of whether the programs are, open to those things.
Thank you. The next question is, how will the application/interview process for your respective residency programs be impacted by the new pass-fail scores for step one around 2023? Dr. Johnson, do you have some insight into that?
I think that the application and interview process is such a unknown at this point that it's hard to say. We're going to Zoom interviews for a lot of programs, and actually was doing Zoom interviews for our fellowship this morning. And so the entire process is getting turned on its head. So short answer is no, I don't know how that's going to impact it. I suspect it will probably make it a bit more egalitarian. However, we've long known that the step 1 and 2 scores don't really correlate to residency performance or whether or not people pass their boards. So it's probably high time that this has happened, but how that shakes out is still unclear.
Right. So I guess a follow-up for that would be if you're in this position, how should you try and prepare with this kind of unknown area? Because it's kind of a loss of a way to stick out. And this was a way for people to do that.
Yes. My suspicion is that back to sort of going to meetings and meeting people is that having somebody who is a strong advocate for you. And we sort of talk about mentorship. And I think that an important thing to say is that you can't rely on a single mentor. And that you need to have several people in your corner who can help you. And it's often useful to have people in different spheres, and maybe you have a surgery mentor and a different research mentor and somebody else who's helping in other areas, as opposed to having just one person who's going to be your angel to make things happen for you.
Right. And so kind of on that same vein, for any of our panelists, how do you suggest students, year 2, find mentors in surgery during this time?
I think short answer is that you leverage your connections. So what does that mean? You guys, people who are on this call right now, you're doing that. You potentially have 6, I'm counting that right, 6 new potential mentors that you can reach out to and ask about how they can sort of guide your interest in surgery and help that shake out. SNMA is a great resource. Obviously, I'm biased. I also know that SNMA is amazing when it comes to sort of helping you get connected. Going to, like it's been said a million times before, going to these conferences. I know travel fee is a lot, but SNMA has regional conferences that only require maybe a bus ticket or a drive down the road. And they have med schools come out, they have residency programs come out. So that's your time to get FaceTime with these administrative folks and sort of talk yourself up, talk about your interests and sort of and develop that. Then also leveraging connections in your own sphere. So if you are at an undergrad where research is being done, don't be afraid to cold email people and see, you know, who research and see who's in what their, you know, field of interest is. And if that's something that interests you, email them, you know, reach out, put that feeler out there. Same with students who are in med school. Utilize your student interest groups, utilize your student affairs office, utilize the alumni office to help you find those people in fields that you're interested in so you can reach out. The worst thing you can do is not do anything.
Thank you for that. And so kind of on the same lines, any advice on getting involved in surgical research if you haven't worked with any surgeons yet? And Dr. Means, you might have some insight also kind of just now getting into your residency.
Yeah, so I would start with, usually if you look on a hospital's page and it specifically outlines different attendings, they have something that shows, it talks about a person's research interests. So once you see like, oh, well, this person's doing research in X and I'm interested in that, then you can see if they have any upcoming projects. You can also just email the residents. I know someone emailed me today and said, oh, are you interested in any, do you have any research projects? And I didn't have any that didn't have any students, but I asked all the other residents in the plastics program. So kind of realizing that once you ask one person, you can ask them like, if you don't, can you just ask the other residents? And hopefully that person is willing to do that. And I think just like we said before, you have to show some initiative. And I think you're gonna have to show some persistence as well, because some people don't check their emails often. And what's a high priority on your list isn't necessarily going to be a high priority on this attendings list who you're emailing. But once that connection is made, then they'll realize, oh, this is someone who I will invest my time in. And I think just going back to the mentorship, I think mentors are so important, but I think you can have a variety of mentors. And so I don't want people to get discouraged if maybe right now you don't have a surgeon mentor. If you're interested in surgery, I think that should obviously be on the list, but there's so much more to medicine. And a mentor who's just in leadership, having a mentor who's just a physician, because being a physician is different than working other jobs. Maybe having a mentor who is a female in that's kind of a category where you fit into. And so not limiting yourself to a mentor that is so narrowly specific to what you're going for that you miss out on the guidance you could get from other people just because they're a little bit different than exactly what you're looking for. Because there's just so much to learn, honestly, just in life outside of just surgery. And so just take advantage of every opportunity.
Absolutely. Okay. The next question is, can you share your thoughts on integrated specialty pathways versus traditional training pathways? For example, I saw that vascular surgery was an integrated 5+0 pathway versus the more traditional 5+2 pathway? What do you recommend to consider when comparing these two program paradigms? Dr. Tillman, do you have any insight into that?
Mute. With the integrated pathways, we do have integrated pathways 5+ in vascular at our institution, and I think that they really the vascular residents really enjoy that, and it's been a great success. Just as was alluded to earlier, it saves you time, and if that's what you're going to do, they seem well prepared and trained after they complete that pathway.
Thank you. Our next question is going to be, how should we as medical students interested in fields such as cardiothoracic surgery go about obtaining and balancing research topics, particularly those for those applying to direct integrated thoracic surgery residencies, given not much data reported on the matches to CT residencies? So Dr. Erhunmwunsee, you might have some insight into this question.
Yeah, so my read of the question is about how do you, I guess, obtain, like, how do you figure out what you need to focus on research-wise in order to be sort of seen as someone who someone want to take into their program? I think there are two ways to do it. One is to focus on what you're interested in, right? Like, you can focus on, like, if you are interested in health disparities like I was or am, or if you're interested in devices, or if you're interested in surgical outcomes, you can find those types of research done, even if not at your own institution. You can, that's a PubMed search to figure out who's working in that area, or again, going to conferences and talking with people who are presenting work that is of interest to you. And then you can go and go up to them and talk, shake their hand, talk with them, and let them know of your interest. I want to remind everyone, and I know it's difficult with travel right now, but there are always opportunities to work even within research with folks who are not at your own institution. It takes a little bit more legwork, but it certainly can be very rewarding. There are opportunities, there are grants, there are scholarships for things like this, and so that opportunity exists. So anyway, that's one way. You figure out what it is that you're interested in and see who's doing that through the ways I just mentioned. Or you could just say, you know what, I really know that this particular surgeon has a great track record with working with medical students or residents, and so I want to connect with that person. And then, like has been stated before, you can email them or Zoom, try to get a Zoom meeting with them and talk to them about your interests and talk to them about what you want to do. I personally am such a fan of doing research early. Obviously, doing research, getting your name on papers it looks good, right? We've already said that. It looks good when you're applying, but I think it also opens you up to that opportunity. We like at least two or maybe half of us on this call also do research. And so one of the misconceptions is that as a surgeon, all you do is operate every day, all day. And that's not true. And we need different perspectives in research. We need different people from different backgrounds in research. We need more Black and brown people in research. So I would hope that everyone on this call would be thinking, hey, do I like research or not? And then potentially think about trying to get an opportunity, even if it's for a month or two or a summer or something, so that you understand better whether that's something for you. But anyway, I think there's more than one way to get connected. And in the end, when you're early on, it doesn't necessarily matter so strongly what you do the research in, right? If you find something that you're like, my first research project was, I think I was looking at like viruses in like a mouse model. Like I have no interest in that a little bit, like at all. Like, no. So, but that experience was good for me because I learned a lot about me, and that I loved checking on the virus every day, every morning. Like I was just like, oh, what happened to them, right? And so I realized that I like research questions and I like sort of following up. And so anyway, it was still a good opportunity for me, even though I don't do anything with that sort of research now.
Okay, thank you so much. You guys, we have 2 more questions. I know we have so many questions, but we have time for 2 more. So our next one is Dr. Johnson. I directed at Dr. Johnson. We've heard many times that age is not a factor, but for instance, if you're starting residency in your 40s and you'd like, for instance, to go into urology, should you be aware of it being in the back of your mind, but not maybe dwell on it? So I think this is concern for like, should age be a factor in going into a surgical specialty?
Truth is, it shouldn't matter. I have no data to support my suspicion, but my suspicion is that it does matter, especially for the surgical subspecialties, which tend to be the most competitive. I know personally at least a handful of older people that are in surgical specialties. I know definitely people in the 30s and people in their 40s. It tends to be less common, but it's not impossible. And at the end of the day, it sort of depends on what sort of candidate you are, and goes back to having that personal narrative of why do you want to do what you want to do, and how is where you're going to go help get there. And I can tell you that our trauma fellowship, actually, we have a long history of training people that were non-traditional learners, shall we say, people that had taken some time, and that was actually, we view as a positive, but not every place has that mentality.
Thank you. Okay, guys. And so we're about to have our last question here. Okay. Are there any questions you feel like are important that we should be asking ourselves if we are considering surgery in general? And I also want to tag on to this question, something to the effect of what you guys wish you knew if you could go back. What do you wish you knew now that you're in surgery? So this question, what are questions you should be asking yourself, and what do you think you knew when you first started? And let's see, Dr. Erhunmwunsee, you're always first, so I'm going to pick you.
I'm actually interested to hear response from one of our attending doctors.
Absolutely. Dr. Erhunmwunsee, do you have something that you would like to add to this?
Yeah, so what do I feel is important? I think I will say it's important to know that you belong, that we belong. I think sometimes, the surgical suite, the ORs may not necessarily, it looks different than potentially some of the neighborhoods or some of the groups that we are most familiar with or most comfortable with. But I know I struggled with that sometimes, being the only, and I just, sometimes there was a lot of bristling because it was like, there's just a different way of thinking and different way of doing things sometimes. But I think, the question to ask yourself is this the way you want to impact people's lives? Do you want to do it through surgery? If the answer is yes, then that means you belong, even if there are some days and times when you may not feel that way. You know what I mean? And that's, again, why mentorship and connection is important.
And then I also wanted to ask Dr. Henry-Tillman if she'd also like to weigh in on that as well. And you're still paused, Dr. Henry-Tillman.
Can you hear me?
Mm-hmm.
The commitment, and Dr. Johnson brought it up earlier. You know, even though you're a surgeon or a physician at all, you know, your clinical work, you know, people say they give you protected time, but they don't. You're still required to be in the operating room, especially if you've had a case and you have to go back for any reasons. You're still required to see patients in the clinic. You're still required to do research, and you're still required to serve your communities and your institutional, the institution that you're part of. And I think the management and the complexity of this is amazing.
No, we may have cut out.
I don't know if I cut out, but
Yes, you're back.
Okay. And just the management and understanding the complexity of it. And the last thing is being able, once you decide on surgery and you decide on your specialty, being able to understand and negotiate the specialty that you're working within. And I think that it's so important that I didn't understand a lot about negotiating and I showed my value, but I didn't necessarily get, my metrics were there, but I didn't, you know, just fight for who I was. And now I do that more often. The merit and the quality and everything is important.
Thank you so much, Dr. Henry-Tillman. And thank you to all our panelists. That was our last question. But this was amazing. I know we had so many more questions, but we really do appreciate your support of the SNMA and our membership and everyone who's been watching, because we really did gain a lot from you guys. Everyone watching, there's going to be a QR code that appears on the screen. We need you guys to go ahead and click on that, scan it, and give us your feedback. But if you're much like me, and I really don't do QR codes, we're also going to drop the link in our live chat for you guys. So go ahead and click that or use our QR code and give us feedback. How can we be better here? How can we continue to provide you guys with more? And keep these things super useful, super helpful, super engaging. In addition, I'd like for us to continue to, stay connected. So go ahead and follow us on Instagram at SNMA_official. Follow us on Twitter at SNMA. And of course, like us on Facebook. But most importantly, you guys, this is just the tip of the iceberg. It only goes up from here, but you have to be a national member. So you have to go to snma.org and become a national member. I'm telling you, no one is paying me to tell you guys this. You have to become a member. Honestly, we constantly are at the forefront of health advocacy, and really advocating for our minority communities, particularly at a time like this, where we're in so much social unrest. And so that kind of helps me segue into our See Us campaign that SNMA has been following. This campaign aims to give imagery behind the fact that racism really is and always has been a public health issue in the United States. The recent murders of our Black brothers and sisters is a clear reminder that this nation is built on the backs of the oppressed and the belief that some humans have less value than others. And you guys were living in the aftermath of that. But as future physicians, we will be treating people who have experienced the trauma from this. And so we stand united at the forefront of defending unity and, most importantly, defending humanity. The SNMA has been committed, this is our mantra, we've been committed to serving underserved communities and supporting underrepresented minority medical students and addressing the needs of those communities from our inception. And we're going to continue to do that. So this is just another reason for you guys to join us on social media and visit our website and follow us on the See Us campaign, because at the end of the day, you really have to see us. And when you do that, the collage that just popped up on the screen with all the national members, post that collage on your social media. or make a collage with your MAPS chapters or your SNMA chapters, or make a picture of yourself black and white and tell us your story, because I see you and the rest of the SNMA see you. But that's on that, and we will continue on to forward that campaign, because this is not just a one-time thing. This is not a one-time commitment. This is something that we're going to continue to do and speak up and take action and take a stance against point blank racism until it's gone. But like, no, not all hope is lost. And I think the hope really does lie in all of us. So how we respond moving forward from this, you guys, really does matter. And I 100% believe in us. But moving on to our next events for Sowing Seeds, our upcoming events to look forward to are our Family Medicine one, July 1st at 8 p.m. EST. After that is Internal Medicine, July 8th. And then we have Anesthesiology, July 15th. And of course, we have PMNR, July 22nd. You guys do not want to miss out on those. They're going to be amazing. If you love today and the amazing panelists we had then, you have to come and join us on these. And again, one more reminder, go to snma.org, become a national member. Don't sleep on it. Thank you guys so much and have a wonderful evening.